All right, let's get right into it. Today, we're tackling a major high-risk medication group for the NCLEX, tricyclic antidepressants, or TCAs. If you're looking to feel rock solid on your safety and prioritization questions, well, you've come to the right place. Let's break this down.
So let's not beat around the bush. The number one reason TCAs show up again and again on the NCLEX is right here. They are deadly in an overdose. I mean, there is zero room for error with this drug class. And that's exactly why the exam hammers it so hard. They need to know you can handle these safely.
Okay, so let's do a quick gut check. Picture it. You walk in and your patient has overdosed on amitriptyline. What is the absolute first thing you do? Your number one priority. If you're hesitating even for a second, that's totally fine, because by the time we're done here, that answer is going to be automatic.
Here's our game plan. First, we'll talk about why TCAs are such a danger zone. Then, we'll march through the core drugs you have to know. After that, we'll hit the big class-wide red flags, what to do in an overdose emergency, and we'll wrap it all up with a rapid-fire NCLEX review. Okay, Section 1, the NCLEX danger zone. Let's really dig into why these older drugs are still such a massive deal on your exam today. So, what are these things actually doing in the body? Well, they boost norepinephrine and serotonin, which helps with depression. That's the intended effect. But here's the kicker. They're not very picky. They also block a bunch of other receptors, muscarinic, alpha-1, and histamine. And this sort of messy action is exactly what causes all the widespread and dangerous side effects. And those side effects lead to these core dangers. The big one to understand is the narrow therapeutic index. That just means the line between a dose that helps and a dose that hurts is incredibly thin. It's like walking a tightrope. This is what leads directly to all the other problems you see here. The fatal overdoses, the scary heart dysrhythmias, the severe anticholinergic effects, we'll get to that, and a huge, huge risk for fall. So let's move into Section 2. Now that we've got the big picture dangers, let's meet the specific drugs you're going to see on the test. We're going to go through them one by one to really cement them in your memory. First up is the heavyweight champ, amitriptyline, brand name Alavil. You can see right away it's super sedating. So what's our priority action? Give it at bedtime, of course. It also causes major orthostatic hypotension, which means fall precautions are absolutely non-negotiable. And with those strong anticholinergic effects, you're always on the lookout for things like constipation and urinary retention. Okay, here's a huge NCLEX pearl. If you see a question with a patient who has depression, plus some kind of chronic nerve pain, and insomnia, your brain needs to light up and scream amitriptyline. But, and this is a big but, remember the second part. It's on the Beers list, which means you want to avoid it in your older adult patients. The risks are just too high. All right, let's put that to the test. Your elderly patient on amitriptyline says, "I feel so dizzy every time I stand up." What is your first immediate action? Before you document, before you call the provider, what do? You have to prioritize their immediate safety. The answer? Get them to sit or lie back down right away. So, if amitriptyline is too risky for older folks, what's the go-to alternative? That would be nortriptyline. And this comparison is a classic NCLEX question. You can see why it's safer. It causes less sedation and has fewer of those gnarly anticholinergic effects. It's not totally risk-free, of course, but it is the preferred choice for the elderly. Now, let's talk about two more really high-yield TCAs that the NCLEX loves to pair with specific conditions. If you see Imipramine, think childhood bedwetting. It's a classic old-school use. And if you see Clomipramine, you need to immediately think of OCD. It's really effective for it. Just burn these pairings into your brain. Now, just when you think all TCAs make you sleepy, there's a plot twist. A couple of them, desipramine and protriptyline, are actually activating. They can amp people up, causing insomnia and anxiety. So the nursing priority gets flipped completely on its head. You give these in the morning, and you would definitely question giving them to a patient who already struggles with anxiety. All right, let's move on to Section 3, the big class-wide red flags. These are the two major toxicities that apply to pretty much all TCAs, and you have to be able to spot them from a mile away. First up is anticholinergic toxicity. And the absolute best way to remember this is the old-school rhyme. Say it with me. Dry as a bone, blind as a bat, mad as a hatter, red as a beet, and hot as a hare. So, if your patient is confused, flushed, and has a fever, don't just assume it's an infection. It could be this. It's a full-blown crisis. Now, for the second and by far the most lethal red flag, cardiotoxicity.
This is the one that kills people. The drug messes with the heart's electrical wiring, causing something called QT prolongation. All you need to know is that a long QT sets the stage for deadly heart rhythms. And that is why a baseline ECG before starting a TCA isn't just a good idea, it is an absolutely essential safety check.
And all this talk about cardiac danger leads us straight into Section 4, the overdose emergency. This is a huge NCLEX topic because it tests everything, recognizing cues, prioritizing, and acting fast when things go sideways. A TCA overdose typically unfolds in a three-step downward spiral. First, the heart's rhythm goes haywire. That's the cardiotoxicity. Then, the brain gets so overstimulated it leads to seizures. And finally, after all that chaos, the central nervous system just gives up, leading to a coma. Heart, brain, then lights out. So, remember that question I asked at the very beginning about the #1 priority for an overdose? Well, here is your answer. IV sodium bicarbonate. This is the antidote for the heart. Think of it like a bodyguard. It swoops in and protects the heart cells from the TCA's toxic effects, helping to prevent those deadly arrhythmias. This is your #1 move. Okay, we are in the home stretch. Section 5, the NCLEX final review. Let's pull everything we've talked about together and lock it in for good. Now, the NCLEX isn't going to test you in a bubble. They want you to compare and contrast. This table is pure gold. For SSRIs, the big bad is serotonin syndrome. For MAOIs, it's hypertensive crisis. But for our TCAs, the #1 deadliest danger is a fatal overdose from cardiotoxicity. Know this chart inside and out.
All right, final pop quiz. Look at these 4 patients. You're the nurse. You can only see one first. Who is it? Patient A asking for a snack? Expected. Patient B with a dry mouth? Common side effect. Patient D with a dry diaper? That's concerning, for sure, urinary retention. But then there's patient C. Tachycardia and confusion. Alarm bells should be ringing.
So, who's the highest priority? It's gotta be patient C, and it's not even a close call. A fast heart rate plus confusion in a patient on a TCA screams cardiotoxicity and anticholinergic toxicity. This patient is the most unstable. They are your immediate priority, period. And that brings us to the bottom line. If you remember nothing else, remember this. TCAs work, sure, but they dry you out, they make you drowsy, and, most importantly, they can stop the heart in an overdose. So when you see a TCA on your exam, your brain needs to immediately flip into safety first mode. It's always, always about safety.